Good evening, everyone.
Good
I'm Dr.
evening.
Sugata Paul. I'm chairman of the scientific committee of OSWB, those who don't know me. Welcome to this webinar. It's a multidisciplinary webinar on headache, and it should help people like me who get a lot of headache in managing headache patients. So we have very experienced speakers today. Before we start the webinar, I would request Dr. Subhashish Nag, our Honorary Secretary of Ophthalmological Society of West Bengal, and Dr. Kajal Prasad Ghosh, President of Ophthalmological Society of West Bengal, to say a few words, and I will then hand over the meeting to our moderators. Dr. Nag, please.
Thank you, Dr. Sugata Paul. A very good evening to all the panelists, the speakers, and our audience. This is a very important meeting, in fact, because headache, as you know, though a very common term, it's not a very easy task when things are not working as you really want them to. And so our scientific committee under Dr. Sugata planned a multidisciplinary meeting whereby we have got experts from various other related fields. And I'm sure by the end of the evening, we will go home wiser and put into use some of the tips and take-home messages into our day-to-day practice. I'm on behalf of OSWB, I'm very delighted that today we have a galaxy of speakers, and of course, our expert home panel is there. I'm thankful to Dr. Pushpita Sahu, who joined from UK, and Dr. Devdas Mukhopadhyay, who joined from Malda as the chairpersons. And then we have our very, very experienced speakers, Dr. Rashmin Gandhi. All of them will be properly introduced by our moderators. And Dr. Rashmin Gandhi is a very senior and very known figure in the ophthalmological circle all over India and beyond. And Ms. Neena Biswas is the Chief of Optometry Services. She is a very diligent optometrist and a very senior one at that. And Dr. Atanu Vishwas, the neurologist. We have Dr. Jairanjan Ram, the psychiatrist, and of course, our very good friend, Dr. Arjun Dasgupta, the ENT surgeon. All of you, a very warm welcome on behalf of OSWB. Without any more, I will pass it over to Dr. Kajal Prasad Ghosh, our president of OSWB. Thank you once again. Sugata, Dr. Kajal Ghosh is there.
Hello, hi, Achi.
Yes, Dr. Kajal.
Hello, শুনতে পাচ্ছো? Am I audible?
Yes, you are audible.
Friends who have gathered here to discuss one symptom which is experienced by all 139 crore people of our country at some part of their lives. As a clinician, what we have to decide what are dangerous headaches and what are innocuous, and make the people aware of the underlying cause and take necessary steps. Many times there are headaches which have no underlying disease, like lack of sleep, exposure to bright light, etc., etc. So far as causes are concerned, headaches, they may be due to ophthalmic cause, the ENT cause, the psychological cause. In this gathering, we have specialists in all subspecialty will enlighten us with their knowledge, and I'm confident all the listeners of this webinar will go back home filling their baskets full of take-home messages. At the end, I like to thank on behalf of the society the speakers who are going to participate in this webinar to make it a grand success. With this word, I like to hand over the moderator for conducting the session. With thanks.
Yes, thank you.
Sugata, one thing, can the audience post questions in the chat box? Please announce that.
Yes. We are also live in YouTube, so I'll be following YouTube as well. And if there is any question in the chat box, I would request
We'll
the
take up at
moderators
the
to
end.
pick up the question during discussion.
So
And
the
I will
audience is
request,
requested.
yes, I'll request the speakers and the panelists to stick to the time. And for the panelists, all the comments should be brief and to the point, please, so that we have a lot of discussion and have a fruitful webinar. I'll now hand over to Dr. Swati Agarwal and Dr. Rajesh Majumdar Choudhury. None of them require any introduction, and they will take the meeting forward. Thank you.
And before that, can I thank Janssen Division of
Janssen,
Johnson
yes.
& Johnson, who have very kindly consented to support this webinar. Thank you, Johnson & Johnson.
The Janssen division, yes, thank you very much.
Oh, man.
And I'll request everyone else to keep mute when the speaker is, when someone else is speaking. Thank you.
Thank you, Dr. Shugato. I'm very much honored to moderate this session of a multidisciplinary approach to headache. And my co-moderator, Dr. Rajesh Majumdar Choudhury, we all know him. He's a thorough gentleman and a very, very good doctor and an oculoplasty surgeon. Let's move forward, and I would like to welcome our chairperson for the evening, Dr. Pushpita Shahu. And is my screen visible? Yes. So she is the ex-president of OSWB and also the former lecturer at VIMS, and Dr. Devdas Mukhopadhyay, who is the director at BKG Institute Malda, and our esteemed panel, Dr. Shujata Guho, who is the director of pediatric ophthalmology and neuro-ophthalmology at Shankar Nethralaya, Kolkata, Dr. Paromita Sanatani, pediatric ophthalmologist and director at Athena Eye Clinic, Kolkata, Dr. Tulika Ghoshal, visiting lecturer at KPC Medical College and Hospital, Dr. Ashish Bichpuria. He's a pediatric ophthalmologist, strabismologist, and neuro-ophthalmologist at Disha Eye Hospital, Siliguri, and Dr. Shubhranshu Sengupta, a senior consultant at CFS. So welcome everybody. Now I'd please welcome Dr. Rajesh Majumdar Choudhury, the moderator, to welcome the speakers.
Thank you so much, Swati. I'm having a bit of a link problem actually. So I have mailed my slides to Shugato. Shugato, if you kindly look into your mail, you'll find I have sent you a mail with the title of our speakers today. Could you kindly, if either Swati or you could do that job, because I cannot link through my desktop today, unfortunately.
Sorry, Shogato, you mean, or myself?
Both of you.
Okay. So, Dr. Agarwal, if you have it.
No, she doesn't have it. I've just mailed it to you.
Okay, I didn't know that. So,
I'm having a bit of problem in link.
Yeah, yes. Just give me 1 second. Shogato has it. I haven't received it yet. Which email?
I've mailed him to him as well.
So sorry, sir. I'm just checking it.
Okay, can we start the talk and then thereafter?
Just 1 second. Give me 1 second.
It's shugato100@gmail.com.
Yeah. Just give me 1 second. So,
Yeah, received it. Yeah.
So please upload that. Or we.
Shogato, have you found it?
Yeah. Give me a moment. I'm just PowerPoint is opening.
Sure. Thank you so much.
So this is the
Shall
PowerPoint.
I read it? Shall I read it out?
Yes, yes.
I'll read it out. It's actually a real pleasure, to invite Rashmin amongst our midst. He's a polyglot and polymath, and his Bengali is sometimes much better than mine. And, we do not, again, need to introduce him, but he is doing great work in Center for Sight, Hyderabad. Next slide, please, Shogato. Mrs. Nina Biswas, I never had the chance to work with Miss Biswas, but have worked at Sunetra a few times, and I hear all good things about her. She's a senior consultant optometrist, and she specializes in vision therapy. Next slide, please. Dr. Otanu Biswas. I have known Dr. Otanu Biswas not just as a great clinician, but as also very empathetic person. I had taken a friend of mine once to him with a very serious condition of his father. So Dr. Otanu Biswas, he's a neurology professor specializing in dementia, and he practices in Bangalore Institute of Neurology, where he's an associate professor. Next slide, please. Dr. Joyranjan Ram is a childhood friend, so it's really a privilege to introduce him here. He's a senior consultant psychiatrist in Apollo Hospitals and his own institution, which is Mental Health Foundation, Kolkata. And next slide again. Dr. Arjun Dasgupta, dear friend and college junior who's doing great work in his field. He's a senior consultant ENT surgeon in CMRI, Kolkata. Thank you. These are the speakers. And Swati, could you kindly now invite Rashmin to give a speech?
Yes. So with this talk, I'd invite Dr. Rashmin Gandhi for giving his talk on managing a case of headache in our everyday clinics, the silent signs we should all know.
Thank you so much. Thank you. I would sincerely like to thank everybody at OSWB. It's always a real pleasure to be part of meetings at OSWB for two reasons. One, I can assault you with my broken Bengalis, and also to see all good friends, colleagues, and seniors as part of this meeting. I'm going to cover some of the signs that we should be looking at in our OPD when we see the patients with headache. I would omit the usual signs or clear signs, which we all will look at, like people with refractive error, people with having ocular surface problems, uveitis or glaucoma, because these are something which we'll be looking at. And instead, I'll be concentrating on those subtle neuro-ophthalmic signs, which we should be looking at in almost all patients with headache. And this would be an interactive case-based discussion. So I'll start with a case of this 28 years old female who comes to you with very gradually progressive loss of vision for the last 6 weeks. But she also said that she has been having headaches before even the loss of vision for the last few months. Her visual acuity has gone down in both the eyes to a considerable degree, and her fundi looks like this. So it's quite obvious when you have the fundus, which is like this, that there is a bilateral disc edema. So a 28-year-old female with a bilateral disc edema who had headaches, bouts of headaches preceding the gradually progressive loss of vision, you know that you probably are dealing with something serious. And the stuff that you need to look at is she having raised intraocular pressure? Now, if the disc edema is so obvious, obviously, we're not going to miss it. But what we want to emphasize here is that look for subtle disc edemas in these patients who have chronic new onset headaches, especially somebody who has other signs like overweight and stuff like that. But what I want to emphasize here, clinically, what are the pointers towards raised intraocular pressure apart from headache? These patients are likely to have tinnitus, and generally described as whooshing sound in the ear, which will be pulsatile. The other important symptom of raised intraocular pressure, which a lot of times we miss, is transient visual obscuration. A lot of these patients would complain of transient visual obscuration, which is quite characteristic when present. Important point to note is that TVOs associated with raised ICP generally last for a few seconds, generally last for less than a minute, versus TVOs which come because of vascular problem, which last a little longer. And of course, transient visual obscurations with migraine last much longer. So TVOs which last for few seconds, less than a minute, TVOs which are brought about, transient visual obscuration, brought about with change of posture. When the patient gets up from a supine position, he gets these TVOs for a few seconds, and then if there is a subtle disc edema, disc hyperemia, you know that you probably are looking at raised intracranial pressure. So headache, transient visual obscuration, tinnitus, look for edema. If it's clear cut, we are not going to miss it. Look for subtle disc edema. Another important sign, of course, this is quite evident in this patient, but a sign of a raised intracranial pressure is this. They can have bilateral 6-nerve pulsing. Here you see patient trying to look to the right and there is an abduction deficit in the right eye, and patient trying to look to the left and abduction deficit in the left eye. That's quite characteristic of raised ICP, often described as false localizing sign. And because of tortuous tenuous course of a 6-nerve, 6-nerve gets affected because in a raised intracranial pressure. So that's about headache. Look for subtle disc edema. Another case of headache in a different age group, 70-year-old female, severe headache, and also loss of vision. Now, again, a disc edema, but here the presentation is acute. The age group is 70 years. And look at this disc. You see, this is in an acute phase, patient already has developed nerve fiber layer infarct. So this is what is described as pallid disc edema. When you say pallid disc edema, means a disc edema with a pallor which is already set in, and it's characteristically it occurs in conditions like GCA, arthritic anterior ischemic ophthalmopathy, where patient can have a disc edema with infarct setting in an acute phase. Generally, otherwise it takes 6 to 8 weeks before the optic nerve infarct or the pallor sets in. These patients characteristically would have much earlier onset of a pallor or nerve fiber layer infarct because of a severe disease process. So older patients, headache, acute, profound visual impairment, you probably are dealing with, or don't forget about arthritic anterior ischemic ophthalmopathy. This is an emergency. These patients require steroids immediately, and steroids are given not so much for improvement of the vision in the same eye, but to preserve the vision in the other eye, because these patients can lose vision very quickly in the other eye. And that's the reason why it's typically you need to act very fast. These patients would have a very high ASR, which will point towards arthritic eye. And you can have in these kind of very classical picture, you see there is a pallid disc edema and also a BRAO. So second case of a headache with loss of vision, unilateral headache, arthritic eye. Now this is the third case, and this is where our judgment and examination comes in. This was a case of a 10-year-old female who was complaining of loss of vision for the last 4 months. She was also having on and off headache for last 4 months. And her optic nerves looked like this. So on the first impression, you will say, oh, 10-year-old female, 4 months, gradual progressive loss of vision, headaches, probably, and bilateral disc edema. You see this nerve fiber layer is all gray here. There is a disc edema in both the eyes. You say maybe you are dealing with raised ICP. But the thing that we should not miss out, and what this patient had, if you did a retroillumination, you found that there was a lot of vitreous cells in both the eyes, which were actually missed in the initial examination. Patient actually had pars planitis, intermediate uveitis in both the eyes. She was losing vision because of cystoid macular edema, and the vitreous cells was a clue as to why patient was having all the problem, and also a subtle disc edema. So while disc edema, gradually progressive loss of vision, you are worried about raised ICP, but also make sure that you rule out uveitic entities like VKH, sympathetic ophthalmia, sarcoidosis can all have disc edema with panuveitis or posterior uveitis. So that was our first segment of headache, what we should not miss. Headache with vision loss. Look at subtle disc edema. What generally you are looking at is IIH, GCA, optic neuritis. Of course, angle closure glaucoma is something which we should not miss and generally would be evident to us. We move track and we go to the second segment. This is a 25-year-old male who had been having some headaches and was complaining of gradual progressive loss of vision in the left eye. You see his left eye has a pallor and visual acuity was 6/60 in the affected eye. So what next would you do in these patients? The other important point that you should always look at is visual fields. And as you find here, patient had a visual field defect, a supratemporal defect in the right eye, and a complete obliteration of visual field in the left eye, what is described as a junctional scotoma. So this patient obviously had chiasmal compression because of presence of pituitary adenoma. Patient had junctional scotoma. These patients can also have bitemporal hemianopia. They can have other associated features like seesaw nystagmus. This patient had a disc pallor. Characteristically, disc pallor in somebody who has a compression of optic chiasm is band-shaped or a bow-shaped. So that's pituitary adenoma in this patient. So that's the second segment. Patients with headaches cannot explain what's going on from the ophthalmic examination, at least perform the confrontation visual fields, and if possible, or if the index of suspicion is high, perform the formal fields. Third segment, headache and pupils. What is it that you don't want to miss out in pupils in somebody who has headache? You see this patient already on the examination has quite a significant amount of ptosis, and see what happens when we are examining the patient with the torchlight. You will see that the right pupil is bigger than the left pupil. So patient with a ptosis with anisocoria with a larger pupil on the side of the ptosis, and you'll find here that the ocular motility is being checked. You'll find that the elevation is deficient. So this is a partial third mode palsy with pupil involvement. Patient had persistent headache. So the third point I want to emphasize with somebody who has headache is look at pupil very carefully. This patient also has a ptosis, has a pupil which is larger. It's not really seen very clearly in the photograph. A third node palsy can present to you with complete or partial ophthalmoplegia. Look at anisocoria, especially when the patient complains of headache, because these patients can be harboring aneurysm of posterior communicating artery, and it can cause. And as you see, the numbers, they are quite scary. 10% of these patients can die before they get medical attention. 50% of the survivors have permanent residual neurological deficit. So the third point is look at the pupil. Again, one more example of why pupils are important. This patient, again, presented with an acute onset headache. You find here there is a mild ptosis, and see what happens to the pupils. The pupils are being examined in a dim and a bright illumination. You find that the difference in the size of the pupil is much larger in the dim illumination versus a bright illumination, signifying that in her left eye, patient has Horner syndrome. Acute onset headache with Horner syndrome is an emergency. Why is it an emergency? Because patient, again, can dissection of the cervical, the carotid arteries can present to you with isolated Horner syndrome. And these patients have headache. A lot of times they present to us first, thinking that maybe the acute onset headache is something to do with refractive error. And again, the numbers can say that about half of these patients who had dissecting carotid aneurysm had isolated Horner syndrome. So point I want to emphasize, patients with headache, look at the pupils carefully. If the pupil is larger, you're probably dealing with a parasympathetic system problem like a third node palsy. Patient can have an isolated mydriasis, which can happen in the patients with migraine, or patients can have isolated Horner syndrome. It can happen with cluster headache, but we have to rule out dissected carotid aneurysm. The reason why it is important to rule this out, and you probably would hear about it in next talks, is because it can throw up an embolus, can lead to stroke or MI. Last patient in this era, in fact, I saw this patient today, a 24-year-old female with a loss of vision for the last 20 days. Vision is 618. She had her Covishield inoculation last week, complaining of headache and loss of vision. We are talking about pupil, why pupil is important. And this patient had a dysthymia in the affected eye. This patient probably developed optic neuritis, and we have been seeing an increased incidence of anti-MOG related optic neuritis in patients who have been having COVID or even after the inoculation. So these patients can come to you with headache, can have an optic neuritis, and eye pain or headache or a face pain can be a present complaint. So 3 things to look for in pupils in patients with headache. Look at the size, whether the pupil is larger or smaller, or patient has RAP. So these are the features of pupil. And the last part, ocular motility. This patient actually was told that he has a sixth nerve palsy with some other issues. He was having severe right-sided headache. But if you look at the ocular motility carefully, you'll find that patient actually has no abduction, no elevation, no adduction, no depression. So not only that patient has headache, but there is complete loss of movement. Patient's vision was fine in this eye. So patient actually had a Tolesa-Hunt syndrome, inflammatory lesion somewhere in the cavernous sinus. So ocular motility, last segment, patients with headache, look for a subtle ocular motility deficit. Do corneal sensation, because these patients can have sixth nerve palsy with a loss of corneal sensation to begin with. So make sure that you look for corneal sensation in all these patients. Patient can have a cavernous sinus or orbital apex lesion. Even a nystagmus. There have been patients who were diagnosed as having congenital nystagmus, a very subtle change of direction of nystagmus when patient looked up and down, had headache, and some of those patients had Arnold chiari malformation. To summarize, what you don't want to miss out, subtle signs in the disc, pupils, visual fields, and ocular motility. I thank all of you for your kind attention. Thank you so much.
Thank you, Dr. Rashmin. That was such a lucidly explained ophthalmological causes of headache, and it was indeed very wonderfully explained. And Dr. Shujata Guho, madam, are you there? Ma'am, you keep on seeing such difficult cases all in your SNOPD. So how do you exactly, like, what is your take on this topic?
So I will first start with an important part of the examination, the history. The history comes first, from which we can differentiate a little bit from the primary headaches to the secondary headaches. Usually headaches which are secondary will have certain characteristics history versus the headaches which are primary, like migraine, like tax, like clusters. So history is one of the important signs. And then we move on to the cover test. The cover test is another important thing in examining a patient with headache. Subtle phorias can actually be unearthed with the cover test. And the pupils come next, a very, very important part of the examination. Subtle neuritis, which starts off with headache, can be actually diagnosed with a RAPD, which starts pretty early in optic neuritis. And then, of course, the slit lamp evaluation with uveitis and vitritis, and indirect ophthalmoscopy, plus a slit lamp biomicroscopy for the subtle disc edema. So I emphasize on the history part of the examination, very important.
Thank you so much, Sujata. That was actually very, very, to the point, and only an expert would be able to do it so lucidly. So we move on to our next speaker. I must say that Rashmin is really lucky for me, because prior to this, I was having difficulty in logging onto my computer. But once Rashmin started speaking, it all seems hunky-dory. So thank you again, Rashmin, for everything.
Your headache was cured.
Thank you. Our next speaker, as we said, is Ms. Nina Biswas. She is a teacher par excellence, and she has been doing great work in visual therapy for such a long time in Kolkata. We're really proud to have you, Mrs. Biswas, amongst us. So the floor is yours.
Thank you. Thank you, Doctor. I'm Nina Biswas from Sumitra Family Eye Care Center. And I'd like to thank Dr. Rashmin Gandhi for such a good start to the thing. And I'll just try to share my screen here. Is my screen visible?
Yes, it is.
Okay, thanks. So I'll be covering headache and non-strabismic binocular vision anomalies. These days, we in this COVID era, we all have been using computers, mobiles, and laptops for all our work, studies, and everything. Even for socializing, we need to use our computers. And we are getting more and more patients with complaints of headache, eye strain. So I'll be dealing with these type of problems. So let's start with the very simple basic thing, that what is binocular single vision, where our brain takes the picture from the two eyes and fuse it into a single image, which helps us in perceiving depth and localizing the objects in space. But we all, as Dr. Sujata was telling us, that we all have small misalignments, which we call as phorias, exophoria, esophoria, or vertical misalignment. And to correct and keep our object of regard as single and clear, our visual system has to work very hard, which causes painful symptoms like frontal headache, temporal headache, eye strain. Sometimes it can be mistaken for migraine, or it is a trigger for migraine also. And the main reason behind all this is that our whole day, 10, 12 hours of work on the computer. And so I think maybe after COVID, these headaches might become the next pandemic. Dr. Sujata mentioned history taking. So that we all know that gives us the clue when the patient tells us whether about his headaches and all, we can follow it up with our few questions to lead him into the direction that how many hours they use the computers, whether what all they do, what distance they keep the computers or mobiles, and how many hours they are using it. And these complaints indicate that a patient has a binocular vision problem. The other important point while taking history taking is usage of questionnaires. We have standardized questionnaires which measure the symptoms before and after the treatment, or we can make a small questionnaire with 4 or 5 important questions like, does your eyes feel tired when reading? Do you feel uncomfortable? Do you have headaches? And while the patient is waiting in the OPD, give them these small questionnaires to fill up. And 0 means they have no symptoms, and 4 means they have a lot of symptoms. So the higher the score tells us that patient has the binocular vision problems. And this will give us an indication after performing the full checkup and giving them treatment like vision therapy and all, we can recheck it and prove that the symptoms have come down. So we'll start with the history. We already have an indication after the history that it might be a binocular vision problem. And while taking vision, we should be taking care that how comfortably patient is looking at distance and near vision chart, whether a patient can read 2-3 lines in the near vision chart comfortably, or they are struggling, moving their head too much or turning their head. And when they are focusing at distance, whether they are taking some time for focusing. So this will give us some idea again. While doing refraction, after doing the uniocular refraction of each eye, we need to do binocular balancing, where we balance the accommodation in the two eyes. And we can do the same check with our seeing the retinoscopic reflex also. It should be equal and clear in the two eyes. That means we have balanced the refraction in an accurate manner. For non-strabismic binocular vision disorders, we can classify them as vergence, accommodative, oculomotor disorders. They don't occur individually, they overlap each other. So a vergence problem will have some accommodation and oculomotor problem also. How do we evaluate them? Phoria measurements with cover test. We should measure it for distance and near, and how much in prism diopters, and whether it's more for, we should keep a record that note that it's more for distance or for near. And from these phorias, we can calculate AC by ratio also. And we need prism bars and prisms to check the positive and negative fusional vergence. There are various ways to do each test. I'm just telling you about the general OPD, what we use. And convergence amplitude, we check it by near point of convergence. And sensory status by measuring the stereopsis by a Titmus fly random or random dot stereopsis and Worth-4 dot test, simple test. So the anomalies can be divergence anomalies or convergence anomalies. And they can be, what type they can be. Normal convergence is when a patient can focus on the target. And if the patient has insufficient convergence, the patient will focus behind the target. In convergence excess, they will focus in front of the target. So the localization will not be perfect. In the same way, we can have divergence, either excess or insufficient. In such a short time, I can't tell you about all of them. I'll just talk about the most common ones. Prevalent of convergence insufficiency is high among the others. And the complaints of asthenopic symptoms, eye strain, headache, blurry vision. Here, when we check, we mainly find them to have exophoria, which is greater at near. And when we check their NPC, we find that it is also receded. How do we do NPC? I'm sure we all are aware of. But instead of using simple pen or a torchlight, if we can add on a 6x9 accommodative target to our fixation target, that will give us a more reliable result. And a tape or a scale will also give a good measurement. And even the fusional ranges will be less in these convergence insufficiency cases. Convergence excess is where the patient is converging too much, and we'll find more esophoria in these cases. And the ability to negate it with their divergence, fusional vergence will be less. AC by A ratio will be high here, and symptoms will be same like headache, blur, diplopia, asthenopia. Coming to accommodative disorders. So accommodation also, either it will be insufficient or it will be too much, or there will be infacility where the patient cannot switch the focus between the near and far and back. Or sometimes we find that there is a spasm of focusing muscle which prevents the eye from fully relaxing. This is happening mostly when we are doing near work or computer work or mobile work all the time. Our eyes, they just are converging and accommodating all the time. So when we look at far away, they are all blurred. They can't focus at all. How do we check the accommodative system? We measure the amplitude. We have some formulas like 15 minus 1/4 of age, which gives us for what age, how much should be the accommodation. And we have certain standardized tests with which we can measure the amplitude of accommodation and compare it with the age-related norm. Same way, we can check the accommodative response. MEM is the most useful method which we can use in OPD very easily and can find whether is patient over-accommodating or under-accommodating. And facility we do with the help of flippers. Interaction between the convergence and accommodative systems is also important, which we find out with the help of AC by A ratio. And lastly, we need to check the oculomotor system also. How stable is the fixation? While doing the cover test, we get an idea of the fixation ability. About 10 seconds each person should be able to comfortably fixate. And then we check saccadic eye movements, pursuit eye movements with the standardized tests. And these eye movements help us in reading and doing our work. So school children with poor saccadic or pursuit eye movements, they will have problem in reading or comfortably studying. So these were the three things: vergence, accommodation, and oculomotor system, which we need to look in our non-strabismic binocular vision anomalies. Usually for a detailed checkup, it takes 30 to 40 minutes. But we can do similar things in a limited setup also with the minimum expenditure also. Like retinoscope we all have, and retinoscope and few cards give us the idea of, we call it MEM test, the lag of accommodation or spasm of accommodation. With a simple pen light and red filter, we can get an idea whether it's accommodation excess or not. With simple flippers, we can measure accommodative insufficiency, ill-sustained accommodation. And the convergence, if it's insufficiencies, can be best measured with a gluten fixation stick with some letters or pictures on the stick for accommodative targets. Once we find out or decide that the patient has these problems, how do we manage the case? First thing is, in case of small refractive errors, latent hyperopias, astigmatisms, glasses do help them. And sometimes we use small ads plus powers in case of accommodative cases, and prisms, base in or base out prisms in case of urgence anomalies. And vision therapy also gives us a very good result. Now, what is vision therapy? It is for each patient, we had individualized programs to help them to improve binocular coordination, stereopsis, focusing skills, their visual motor coordination. We start by doing this test where the patient is and improve on it. And we do it slowly, and we prefer to do the office-based vision therapy. It can be once a week for 30-40 minutes, and then give them home exercises for 5 minutes every day. And for long distance patients, even once a month is okay. In the COVID era, we are even doing long distance on computer also. We are helping patients with the vision therapy. And we have various cards, various vectograms and instruments in the clinic, and computerized vision therapy is also there. Even for the home assignments also, we can give them few sessions for doing at home, and then review them regularly and improve on them and make their vision comfortable. So as I told you earlier, that in this COVID time or before COVID time, and now we are going towards digitalization, everything is on computers and smartphones. So they are our partners and they are our friends. We have to work with computers and mobiles, and we have to keep our eye system stronger and comfortable with the help of these various availabilities, and make sure that every patient has a good, comfortable binocular vision. Thank you.
Thank you so much. Thank you. We have Dr. Paramita Shanatani here, who does great work in this particular field. So I would like to have Paramita's take on this particular issue, because we know we do not have the facility of having such an experienced optometrist in our clinics. Usually we do not. So Paramita, first I'll have your, a short take-home point for our doctors who are practicing in the periphery. And then I would like Pushpita to also chip in and tell us what she feels is one important thing we should look at these patients when they come to our clinics. Paramita first.
Yeah. Thank you, Rajesh. I think Nina has covered everything. So there's very little to add, but I would just like to emphasize that this non-strabismic BSP anomalies, they are very important. Sometimes when a child comes to us or a person comes to us with headache, and we find that the child or the patient has a 6x6 vision, we immediately say that it's not due to the eye, but that is not so. It's not just having a 6x6 vision. You can still have BSP anomalies that can give rise to headaches. What Nina said about refraction, that is really so important, because if you have an uncorrected astigmatism, or let us say suboptimally corrected astigmatism, the child might be able, or the person might be able to read up to 6.6, slowly sort of stumbling along, but they might get headaches. So you need to give them the full correction refraction full correction hypermetropia, because often patients will read, even if with a hypermetropia, with a latent hypermetropia. But unless you correct it, it can give rise to very bad headaches. And another thing that is happening quite often now, especially in COVID era, is an overcorrection of myopia. Maybe because of this so much of computer use, or maybe because of the stress. Sometimes, if especially with children, if an undilated retinoscope refraction is done, it is possible to overcorrect. So we have to really guard against overcorrecting the myopia, which could lead to headaches. And of course, convergence deficiencies is said. And there's one other thing that I'd like to mention, and that is an uncorrected phoria. Sometimes, especially in exophoria, patients can control it. So the patient seems to have no problems, but the moment you dissociate, it might even be a 30 diopter, 40 diopter phoria that the patient is controlling with effort, and that can give rise to horrible headaches. So that's another thing.
Let's discuss this in more detail during a panel session. Pushpita, the quick points, please, from you. A take-home point for our practitioners in the periphery.
A take-home point, as far as I can see, the approach to this webinar is for comprehensive ophthalmologists who are faced with headaches in their clinic, and not to go into details of ophthalmic or anything like that, right? So I look at it, all of us face headache patients in our clinic. So we have to divide it into more sinister headache and those which are not that sinister headache. Now, there are headaches which obvious cause, like Dr. Gandhi said, with ptosis, with pupillary change, etc., where obvious your attention is drawn to that and you become, on your toes to find out if there's anything wrong. But most of the cases that come to the eye patient, to the eye ophthalmologist, is headaches where the patient doesn't know the cause, So from that point of view, Sujata, what she said is extremely important. A very good history taking that will immediately tell you whether you're dealing with a more sinister cause or whether you are dealing with this orthoptic, which is very, very common, and we very often miss it because we don't think about convergence deficiency and all that sort of thing. So basically, I'm saying that this webinar, we should look at it, headaches with more sinister and headaches which we see every day, where the patient comes, we don't find anything because we don't look into these muscle anomalies, these things that Mr. Biswas was telling about. That's all I want to say. I don't want to say anything more.
We just want to dwell on the basics and, so that we know exactly what's happening without actually going into much detail of neuro-ophthalmology problems. So we can at least, see these patients properly and refer as when necessary. Swati, would you take over now?
Rajesh, can I add a few lines to it?
Okay, Devdasda. Okay.
Yeah, sorry to interrupt.
No,
I expected the discussion should be open with a simple flow chart. Impression of a general ophthalmologist, how he decides and approach a patient with headache. But we are going inside the individual causes, and they are in details. I think as a general ophthalmologist, I needed a flow chart, how we approach.
Yes, sir.
I think it will come later. Maybe
yes, sir.
Let's do that during our panel discussion. All our speakers, we have a
should have been started in the beginning panel. Should be like this. Anyway, carry on, please.
After we've done with the talks, we'll definitely have a discussion of our take-home points and how we should be dealing with all this in our clinics from a comprehensive ophthalmologist point of view. And with that note, we move forward to our next talk by Dr. Otonu Biswas, the Professor of Neurology, Bangor Institute of Neurosciences, and he'll be telling us about the neurological causes of common headache. Sir, over to you.
Good evening, everyone. First of all, let me share my screen. First of all, I like to thank Dr. Rajesh Majumdar Chaudhary and also the Ophthalmological Society of West Bengal for inviting me to speak on this forum. It is a difficult job for me because to cover the headache in a very short period of time, but I try to do that by giving some ideas about how the headache can be serious and can be a very non-serious thing. Now, talking about the burden of headache in our society, it is said that headache is nearly universal symptom. Almost all of us have headache at some point of time in our life. And it can be the complex and heterogeneous set of causes. It is estimated that nearly half of the world's adults have an active headache disorder. So you can imagine how common the headache symptom is. It is probably the most common neurological disorder in the community. And this is what is the burden of headache in our country. This was a study by Global Burden of Disease Initiative of India, and it is going to be published in this month in Lancet Public Health Journal. I'm one of the co-authors. The tensile headache type of headache is probably the most common variety, and it accounts for almost 35% of individual in the community. And migraine is the next common cause, around 21 to 22% of the community suffering from migraine. So, but it is not only the numbers, but also because of the chronicity of the disease. The person who is suffering from migraine or the tension type headache, they suffer for a long duration. So it is another, in epidemiological perspective, there is a term called the DALI, or the disability adjust here. That means how much disability the disease is and how much person who is having headache can have difficulty in performing his activities in his office, in his home. So he becomes disabled for some time. So this disability index is very important. And of the neurological disorder, migraine is probably the commonest cause of disability, and it is causing a significant daily burden. Now coming to the prevalence across the age groups, the tension type headache is almost equal in male and female. It can happen in all age groups, starting from age of 10, but migraine, the females suffer more than the men, and usually picks up into the middle age between the 30s and 40s. Now coming to the different classifications. The most important classification which is used all over the world is the International Classification of Headache Disorder. And in 2018, the third edition was published. It states that it grouped into two, either the primary headache or the secondary headache. Primary means there is no apparent cause. And the secondary headaches usually having an underlying cause like the trauma, the intracranial vascular disorder, or the non-vascular disorder, maybe tumors, maybe infection, maybe substance abuse or withdrawal of the substance. And there may be a host of other causes, including the diseases of the sinuses, the eyes, the teeth, mouth, and of course the psychiatric disorders. Then the primary headaches. The most common variety I told you is the tension type headache, and of course the migraine. But other primary headaches are the trigeminal autonomic cephalgias, or the TACs, which includes the cluster headache, paroxysmal hemicrania, the SUNA and the SUNT, the hemicrania continua, and most of primary headaches, which are usually less common and very less frequently seen. So coming to the evaluation of a patient with headache, as emphasized by all my previous speakers, history taking is very important. For any neurological diseases, we rely upon the history, but for headache, it is the history and the history that gives you an idea about what is the type of headache and in which point of time you want to go for a detailed investigations. So this history I will come to one by one. The type of headache. I told you the commonest variety of headache is the tension type headache, which usually happens in all age group. It can affect male and female equally. Usually a pressure-like headache. The headache may start bilaterally. It can be occipital headache. Usually spasm of the muscle is the cause. Whereas in migrainous headache, it is unilateral. It may be bilateral, but unilateral is the usual thing, with pulsatile nature of the headache. Associated symptoms like nausea, vomiting is there. There may be photophobia, phonophobia, and osmophobia. So it builds up over a time of period, some few minutes, then last for about 4 to 72 hours. And these episodes recurs every some other days. So this is common types of headache, but one person may have a different kinds of headache, might have both migrainous headache as well as the tension type headache. So knowing the character of the headache is very important to know that which type of headache the patient is having, or the combination of the mixed type of headache he or she is having. Now, onset of headache. A stable headache for many years. This is very important. Many patients, they come with a 2 weeks history of headache. But if you ask them, if you probe further, they come up with the idea that yes, they used to have headache on going out or exposure to sun or by journeying. That they usually ignore because these are usual headache. But they are suffering from a long-standing migrainous headache or tension type headache. So headache for many years, onset in childhood and adolescence, this clearly picks up that this person is having probably a migrainous headache. But a recent onset headache or overall headache is very important clue that probably you are dealing with secondary cause for headache. And this thunderclap headache, that means all of a sudden the headache builds up within seconds or minutes. This can be because of the patient complaint that is their worst ever headache in their lifetime. This could be because of the intracerebral hemorrhage or subarachnoid hemorrhage, cerebral venous thrombosis, or maybe arterial disc dissection, pituitary apoplexy, spontaneous intracerebral hypotension, or the reversible cerebral vasoconstriction like syndrome. Onset of headache above the age of 50 years is suggests intracranial lesion, or maybe the giant cell arteritis, as Dr. Gandhi has already given you an example. History of head injury, very important clue that there may be a subtle head injury in an elderly person with headache that may be because of subdural hematoma, chronic subdural hematoma, or it could be because of the post-traumatic dissection of the carotids, or there may be a post-traumatic headache if headache continues even after treatment of the trauma and it persists for a long duration. Frequency and periodicity is very important. Usually there are two kinds of headache, episodic headache and the chronic headache. Episodic migraine, already told, it happens once or twice or thrice in a month, but it can, if this frequency goes up and if the headache continues for more than 15 days a month, and if it lasts for more than 3 months time, then we call them is a chronic migraine. Similarly, the tension type headache can be infrequent, less than 12 days per year. It can be frequent, like between 12 to 180 days. That means 6 months per year. But it can be chronic if the more than 15 days, if the more than 15 days of the month, the person is having headaches, the chronic tension type headache. Similarly, the cluster headache. It can be episodic cluster headache, which happens for a duration of 12 days at a stretch, or maybe for months. Then there is a totally headache-free interval remission for more than 3 months. That is episodic cluster type headache. But it can be chronic if it continues for a longer duration than 1 year without remission, or the remission for less than 3 months. Then it is called the chronic cluster type headache. So headache diary, maintaining a headache diary. Always we ask for maintaining a headache diary by to the patients. It gives you an idea about the frequency, the duration, the intensity, the triggers, and also the medication use. Medication use is very important. Medication overuse can cause a chronic daily headache. I will come to that later on. Now there may be a secondary cause of chronic daily headache. This also needs to be taken into account, and one needs to look into this and investigate for this. Disorder of the CSF dynamics, idiopathic intracranial hypertension can produce chronic daily headache. Or there may be a CSF leak with hypotension, cerebral hypotension, that also can produce chronic daily headache. Intracranial stress accumulation, giant cell arteritis, cerebrovascular disease, all sorts of trauma, infections, and of course the medication overuse headache. The progressively increasing headache or severe headache within 3 months, one should look into that this probably is not the primary headache. There might be a secondary cause. Headaches aggravated or relieved by assuming upright posture or supine posture. This postural headache symptom is very important clue that probably patient hypotension, CSF leak. Headaches brought by Valsalva maneuver. Probably there is an underlying cerebral neoplasm or some mass lesion. If there is a neurological symptom like vision, like there is some loss of speech, or there is confusion state, or there may be hemiparesis, focal lateralizing neurological signs, this gives a clue that there may be a secondary cause. You need to go for imaging, looking for the disc and finding papilledema, also a clue that there may be a secondary cause. Systemic symptom, weight loss, fever, myalgia, don't forget to go for a secondary cause. Or if there is a sudden onset headache and onset above the age of 50, must be investigated in detail. Medication overuse headache. This is very common when the person is suffering from chronic migraine or tension type headache. They usually self-medicate and they take opioids, barbiturates, and all sorts of combination analgesics. They usually suffer from chronic daily headache, and they are not amenable to treatment unless you gradually withdraw this over-the-counter medicines or the rescue medicines. And these also have a very duration. If the ergots are continued for 1.7 years, usually they develop a chronic medication overuse headache. Triptans, 2.7 years. And for NSAID, it takes 4.8 years chronic use to produce a chronic medication overuse headache. The cluster headache, I was told it is the episodic cluster headache and also the chronic cluster headache. The cluster headache typically affects the head, the pain around the eyes and beneath, around the orbital area and the front area and also the temporal area. It is usually associated with severe autonomic features like watering from the eyes, and also the dystosis. There may be a miosis. There may be associated watering from the nose. Usually the cluster headache begins at night, making the person become sleepless, and it builds up in a few hours. Then it goes on almost 1 to 3 attacks per 24 hours. And this attacks continues for a few days. Then when the cluster, there is cluster headache, and then is a attack-free period for some time. So this cluster headache is probably the most severe form of the primary headaches. And also the other form of the headaches, which comes, the severe form is the SUNCT and the SUNA. I will come to that in a short while from now. The temporal profile. Chronic daily headache can be because of the migraine, can be because of the tension type headache, with autonomic features. It can be because of the cluster headache or the hemicrania continua. I already have described all these things. Hemicrania continua or this episodic chronic persistent hemicrania. Usually the headache lasts for 2 to 30 minutes, and it is endomethacin responsive headache. It affects both men and female equally, whereas cluster headache is usually a disorder most commonly seen in men. A headache that usually unremitting from onset and without relief is called the new daily persistent headache. Sometimes the patient comes with a shorter duration of headache. This has started just 2 weeks back, and it is almost daily. This headache is continuing. We need to investigate that to rule out the secondary cause. But most of the time, this is because of migraine or the TTH. A chronic continuous unilateral headache with moderate severity, superimposed attacks of more intense pain associated with autonomic features suggest a diagnosis of hemicrania continua, and should be tried in these patients. Endomethacin responsive syndrome suggests that there is hemicrania continua, a variety of trigeminal autonomic cephalgia. And neuralgic pain in the occipital region or the trigeminal nerve distribution with a sharp shooting electric shock-like pain with numerous episodes per day is is triggered by any sensory stimulation like the exposure to cold or touch or by chewing. It usually suggests a neuralgic pain, either occipital neuralgia, trigeminal neuralgia, or glossopharyngeal neuralgia. Time of the day and the precipitating factors, very important. Cluster usually makes a person awake from sleep, from a sound sleep. Migraine usually starts in the morning hours, but can at any time of the day. Tension type headache most of the time usually begins to rise in the evening hours after a day's work. Those who are suffering from obstructive sleep usually have headache and awakening. To differentiate cluster headache from the hypnic headache is usually above the age of 50. They usually have bilateral headache and usually do not have autonomic symptoms. This is the primary hypnic headache. This is not a very severe or serious nature, but cluster headache is very serious, intense headache, unilateral onset, autonomic symptoms. Triggers, as you all know, migraine has a host of triggers like bright menstruation, change in the weather, caffeine withdrawal, fasting, alcohol, sleeping more or less than usual, stress, and all sorts of things. Cluster headache usually gets precipitated by alcohol. But if there is anything like this, bending or lifting or coughing or valsalva maneuver that brings up the headache, it probably suggests an intracranial lesion of the posterior fossa tumor, exertional headache, or the sexual activity. If there is a headache, it could be a benign exertional headache, but one need to exclude that there might be a subarachnoid hemorrhage or arterial dissection. Intermediate headache that are worsened by sitting or standing and improved by lying down is suggestive of cerebral hypotension. So it improves by lying down and it gets aggravated by standing posture. It is the primary cause, maybe the CSF leak after a lumbar puncture, or maybe a history of trauma or surgical procedure. There might be a spontaneous CSF leak if there's no history of such. Trigeminal neuralgia and glossopharyngeal neuralgia, there are triggers which are location. Trigeminal neuralgia, glossopharyngeal neuralgia has a typical distribution of the headache. Carotid artery dissection usually have unilateral headache, neck pain, facial pain, and frequently associated with ipsilateral Horner syndrome. Dr. Gandhi has shown you once. Migraine is maybe unilateral, but maybe bilateral, but cluster is always unilateral, usually on the same side again and again in a particular cluster, but it may switch over to some other side in the next cluster. Tension time headache may begin in the neck, but it can be also in the occipital pain. Severity, one needs to know the severity. Many patients, if they're having functional component, they will describe that the very severe headache, but if you ask them to scale between 0 and 10, you can judge what the severity is. And the nature of the headache. If the severe headache, usually our thunderclap headache, subarachnoid hemorrhage, or CVS and meningitis needs to be excluded. Premonitory symptom in migraine is very important with depression, euphoria symptom, irritability, somatic symptom like hunger or diarrhea. Then there might be aura, visual, either positive or negative symptom. And there might be a brainstem aura if there is a vertigo symptom, brainstem migraine, or hemiplegic migraine can have motor weakness. Accompanying symptoms usually have nausea, vomiting, photo and phonophobia, and osmophobia. Osmophobia is very classical, but very rare. There might be associated autonomic symptom or associated symptom. I've already told you that there might be a Horner syndrome suggesting carotid dissection. There may be visual loss like in giant cell arteritis, temporomandibular joint dysfunction. There might be associated fever, focal neurological deficit, purulent discharge from the nose, all suggesting a sinusitis. Or there might be a suggestion of the transient visual obscuration or standing or pulsal tinnitus or diplopia and papilloma suggesting a raised tension.
One more minute, Dr. Biswas.
Yes, please. Sir. Something about the trigeminal autonomic cephalgia, which is, there is a classification called the headache, paroxysmal headache, and the SUNA or SUNC. I'll not go into detail about this. These are very short-lasting headache, SUNC and SUNA, lasting for a few seconds, associated with autonomic symptoms like conjunctival injection or lacrimation. And they're are usually classified according to the time duration. The sunk and soon are very brief. Many times a day can happen between 5 seconds to 4 minutes. But when there is, it lasts for 2 to 30 minutes, is paroxysmal hemicrania, and lasting more than 15 to 180 minutes, and happening in a cluster. It is called the cluster headache. All these trigeminal autonomic cephalgia, they are usually unilateral headache associated with various autonomic dysfunction like lacrimation, like changes. There may be ptosis, there may be some other things. And usually there are different types of treatment. If you classify them, the paroxysmal hemicrania usually responsive to indomethacin, cluster headache usually responsive to sumatriptan, and the chronic treatment requires verapamil or some other thing. Now, the unilateral headache can be migraine, can be paroxysmal hemicrania, or sunk and cluster headache. There are different setting points in between them, the time duration, the frequency, and of course, the indomethacin responsiveness, autonomic features, and others. This is the classical different location and the type of the headache. Now, what are the red flags? That is very important when you ask for an investigation, when there is a head injury or neck injury, when there is new onset headache, or there is worsening pattern of the existing headache, or new level of pain. It's the worst ever headache, abrupt or split-second onset, triggered by valsalva maneuver, triggered by exhaustion, triggered by sexual activity. One needs to investigate. Headache during pregnancy and puerperium, headache after the age of 50 years, or there is any neurological signs and symptom like seizure, confusion, impaired alertness, weakness, or papilledema, systemic illness, secondary risk factors, or if there is any immunosuppressive condition like HIV, compromised host. This patient is to be investigated in detail. So brain tumor, I'm not going to detail. IIH already has been told that this is usually a female patient who are obese. They usually have headache followed by visual loss, pulsatile tinnitus, diplopia. They usually have normal neuroimaging. They might have a S6 nerve palsy because of the raised intracranial pressure and false localizing sign. Normal CSF constituents with a raised CSF pressure of 25 centimeter. And there are a host of secondary causes of pseudotumor cerebri, like that of the cortical venous thrombosis, some drugs, antibiotics, and hypervitaminosis A. Low pressure CSF, I have already told it, but there are maybe associated cerebral meningeal enhancement on contrast examination, and there may be a sagging of the brain with subdural collection in the brain imaging, and there is a low CSF pressure. Now, when we ask for the imaging, what imaging you want to do? MRI is the first imaging modality for any suspected secondary cause, or if there is unsuspected case of secondary headache, if you want to do an imaging, you need to do an MRI, and a contrast MRI is very important. But CT scan is preferred where there is hemorrhage or there is a history of trauma. And sometimes the angiography and the phenography is important to look for the cerebral venous thrombosis, or if there is any arterial dissection, or there is anything like that. So this is a flow chart. I stop here. Thank you very much for your patience hearing.
Thank you, sir. That was a very extensive talk, and I'm sure I'll have to go back to YouTube recording to gain more knowledge and gain more insights. And Dr. Tulika Ghoshal, would you please tell us a take-home point from this?
Right. I think everyone has reiterated how important history is. But I think from a comprehensive ophthalmologist point of view, the most important thing is to differentiate ophthalmological causes and non-ophthalmological causes of headache and know when to refer the patient to another subspecialty or specialty. So know when to refer to neurology or ENT or any one of the other specialties which are associated with headaches. I think that is really important.
Thank you, Dr. Tilikadi. We understood how important history taking is. So Doctor, I would also like to ask Dr. Devdas Mukherjee, sir, what do you feel like should be when a patient enters to the clinic with a history of headache? How do you deal with the patient? What is your sequential steps or the flow chart, as you were saying?
Thank you for asking me. I'm comprehensive ophthalmology. I deal a huge number of headache patients in my settings, and most of them are coming from the rural areas, illiterate, and they're many a times psychologically deprived. This is the background, but many a times it comes with something else. My simple thing, I was fed with some basic reports, just like the refractive errors and intraocular pressure by say eye care or NCT. These two information comes to me. I segregate the patient in two ways: whether the patients, I'm dealing a patient with a red eye or not red eye. If the red eye, definitely is going to the ophthalmology and I look for it. And if it is not red eye, then I go for something. Simple thing, I start with my slit lamp examination, sweep my slit from one side to the other and gain as many as information as possible. Like the status of the cornea, anterior chamber, any abnormality in the iris, people, corneal haze, anterior chamber, anything abnormality, and Van Herrick's. Because many a times angle closure glaucoma or suspect mimics the feature of migraine. When the patient come to a clinic setting, it is the daytime, people is mused, patient is not having headache, and this thing I always, then I go for obviously to look at the disc straight away, cupping, normal, or having any swelling of what sort, that will be decided later. Third point is that quickly corroborating with my refractive error status, I do a quick convergence test and the binocularity. Very quick. It all takes about me 5 minutes to come to a reasonable short listing of diagnosis. And if necessary, I go for the test. If it is migraine, I explain the patient very 1 or 2 sentences and give a treatment. And unnecessarily, unless I've got a very suspicion to do a CT scan or MRI, I don't advise. Tell the patient to come back. And of course, I ask 3 questions about the simple non-red eye headache. How long you are suffering from this? How long does it last? How intense? Because the rural people, they can't say. I ask them, if I say in Bengali, মাথা ব্যথার সময় তুমি কি কাজ করতে পারো না না তোমাকে শুয়ে পড়তে হয়? I get some self-explanatory answer from them. I deduce all these things and go for a simple treatment of what I think is necessary. This is a simple flow chart for me.
Beautifully summed up, sir. And Dr. Atanu, I'd also like the thing of medicine overuse for these headaches. And I've seen people having 2 to 3 or 4 analgesics in a day for over years. I'm sure our next speaker would be able to shed some light on that. And over to you, Dr. Rajesh Majumdar Chaudhary. Please invite our next speaker.
Thank you, Swati. Devdasda, I must say that it was brilliant. You know, the way you summed it up, I think that actually hits the nail on the head. And that's what we are planning to achieve through this webinar today. You know, for me, actually inviting Dr. Ram is, honestly speaking, the reason I'm here today. That's my highlight of my, what I'm doing today. You know, it gives me really great pleasure to invite him. He's a childhood friend, and it's a privilege and honor to have him with us. He's busy. He's doing other things as well today, but later on in the evening. But today he has met some time for us. So over to you, Jaranjan, or as we call him, Jaja, to illuminate us regarding all these myths which are going around about tension headache. How will you bust them? Thank you so much.
Yeah. Just let me, right. I'm still terrible in, can you see the, right.
Yes, it's there.
Right. Yes. Thank you, Rajesh. Thank you, everyone, for inviting me here. So I will go straight to the point, really. Tension headache, busting some myths. See, what I will do is, as Dr. Mukherjee was saying, how to approach a patient who comes with headache, and I will be talking from a very narrow perspective. I think most of it has been covered by my previous speakers, and I will just stick to my subject and then focus mostly on the last part, and I promise to be very brief. So, when a person comes with headache, and we have to first suspect that it is a tension headache. And to be honest, it's not rocket science. And you do some basic examination, get a clue that yes, it could be a tension headache. Then the second task, which we have all of us are aware, which Dr. Gandhi and others and Dr. Biswas have highlighted, Ms. Biswas has also highlighted, that we need to exclude other causes, which is slightly more difficult, but that too is not rocket science. I think the challenge comes, as Dr. Mukherjee said, that how do we guide the patient correctly, and if it is tension headache. And I think it is a bit harder, but that too is, again, you don't need to be a PhD in anything to guide the patient correctly, but you can do it intuitively in a very ethical manner. I won't go into great details of about the basics. Essentially, tension type headache is quite common. People who come to us or go to all of you first have chronic tension type headache. Patients usually do not seek medical care and usually successfully self-treat, and a lot has been said about the description. The point to note is that for episodic tension type headache, it's a very self-limiting condition. Majority of patients do not seek treatment. It is those with chronic tension type headache, they come and would seek out help. And the interesting fact is it's possibly one of the most common type of headache. And the chronic tension type headache occurs in about 2 to 3% of the population in most studies, which is quite a high number if you think that 2 to 3% of the population. The surprising thing is that only 3% of patients consulting their physician for headache had tension type headache, whereas 94% had migraine or probable migraine. So I think we need to be very careful about what we are dealing with. In my own clinical practice, I think these two conditions I need to kind of delineate, because the management at least can be done by us if it is migraine, if it is tension type headache, or in a more complex situation, both can coexist. Again, muscle contraction is often considered to be the etiology of pain, but there is very little evidence to support this. Psychological stress is the most common trigger for tension type headache. Extended periods of psychological stress may play a role, which we are now seeing. Also, working from home, working for home has increased the incidence of tension type headache. Majority of people have a disturbed sleep pattern, are easily fatigued, and complain of hyperalgesia. So often people who come to us with tension type headache also complain of other aches and pain all over the body, and they take great amount of time in describing the exact nature of pain. And often if you are running a busy clinic, it can be taxing to listen to great detail about the description of the pain. Pathophysiology, all of you know much more about it. I'm not just going into great details about it. It's the release and activation of inflammatory agents, which leads to sensitization in migraine of peripheral trigeminal afferents, and ultimately in central hypersensitivity. In tension type headache, the major nociceptor is the pericranial musculature. So essentially, the mechanism is the same. Anxiety and depression can be present in those with tension type of headache, but they are not comorbid. and it's not a cause and effect. So a lot of people would deny actually they have anxiety or depression, but they describe tension type headache. And often this becomes tricky, and I will explain it to you why. Differential consideration, a great deal has been said about it. I'm not going to mention about it. Migraine, I think, is something which we all need to distinguish carefully. So, we come to this whole question of how to guide a patient. And I will give you a very typical scenario, which I think all of you will agree. So if you see this part of the slide, so a patient comes, experiences chronic headache, comes for consultation. He has got this thick bunch of papers. He has gone to Vellore, he has gone to Shankar Netralaya, he has gone everywhere, and he comes with this thick bunch of papers. So you again evaluate, advise, prescribe medicine. The patient reports of no relief. Investigation, you order investigation. Investigations are negative. The physician is relieved that there is no major problem, organic problem, but the patient is perplexed. The patient doesn't believe you that there could be no problem because he's experiencing the headache. So then you look for psychological stress. You ask about family life, job stress, marital issues. Are the children kind of doing okay? And the patient often denies. And they feel that, why are you asking about all these questions when, he has come to you for headache? So the patient feels misunderstood, requests more tests. The physician, we become irritated. So what we do, we withdraw and refer to specialist, and the patient doctor shops. So this whole pattern goes on, and people come with great bundles of paper where they are quite dissatisfied. They don't want to believe that it is a tension type headache, and it's kind of not emanating from anything more serious. So if you look into who is to blame for this, I think we have to blame it on this person. This is a guy who died in 1650, which is about 370 years from now he died. His name is René Descartes. He is a French philosopher, and he said that mind and body are separate. So Descartes had this great influence on the way we think, insisting that mind and body, they are two separate entities, and he espoused this philosophy which talks about mind and body dualism. Now, the sad part is that even after 370 odd years after his death, somehow we are not able to get rid of this idea. The real fact is that there is nothing called the mind. Everything is located in the brain. But somehow, when you talk to people about psychological stress, the automatic assumption is that there is something wrong with the mind. In reality, whatever we are experiencing, whatever we are feeling, everything is happening within the brain. And it is this kind of lack of acknowledgement amongst us, amongst everyone, which leads people to take this diagnosis of stress-related headache, maybe at times in negative ways. So therefore, I think we need to be sensitive about how we are giving this fact of information that yes, there is something wrong, but it is not what you think it is. So the way we deliver this message, I think, is very important. Again, there is a lot of literature regarding what is the best way to deal with tension type headache. And apart from lifestyle measures, which many of us find difficult to advise in a very busy, clinic, which all of you would have. But the fact is that very low dose tricyclic antidepressants, amitriptyline, is one of the best drugs. It is an extremely cheap medicine, and even in low doses ranging from 10 to 50, it is very useful. For tension type headache in Indian population, you rarely have to go higher than 50, but often many people who are brave go up to 100. But in real clinical practice, you can actually do a lot of good to a lot of people if you prescribe, within the range of 25 to 50. All of you would be aware that glaucoma is one of the major contraindications of prescribing tricyclic antidepressants, and you are in the best position to judge that. Cardiac conduction defects are relative contraindication, but again, at very low doses, usually you can also prescribe amitriptyline. And amitriptyline is one of the best ways which can actually provide a great deal of relief. Now, I think my main point which I want to say is what not to say. And I think what not to say is that there is nothing wrong with you. Apnar kichui hoini. I think people then feel very disappointed because we must acknowledge that the headache for them is real. They are, living with this headache, which is quite incapacitating. In our attempts to reassure the patient, when we say that you do not have apna kishui haini, you don't have anything, we actually possibly convey to the patient that they misunderstand us, because for them the problem is genuine, and when we say apna kishui haini, they think that we are ignoring their problems. So I think this messaging has to be right, and if we are confident about it is a tension type headache, I think any of us can manage with very low doses of amitriptyline, giving some sound basic advice about sleep hygiene, and that would bring great relief to the patient. Thank you. I think that's all I had to say.
Thank you so much, Jaja. You, as usual, have done a great job. And it's so important to take home message that, it's important for us to validate the patient's concern. When they're coming to us with a problem, it is not really for us to trivialize that and say, oh, kichu hoyni, apni bari chole jan, ghumiye nin, barate chole jan, it will go away. I think what Dr. Ram has said here, that it's a genuine concern for the patient, and we have to really do something about it. So Ashish Bijpuria is one of our up-and-coming neuro-ophthalmologists from up north, from Shiliguri. So I'd like to ask Ashish about what is his take on what Dr. Ram has just said, and especially vis-a-vis your epidemiological profile. What kind of patients you see are coming with you with this particular kind of problem? Unmute, Ashish. Unmute.
Stress is a very important factor. So stress-related, this tension headache is very common even in COVID era also. Because of that, stress is everywhere. Even I am feeling sometimes tension type headache because everyone is in stress. Like we are not seeing patients. Some patient losing job, residing single and unmarried, especially young patients, females. I have seen so many patients, females especially. Those who lose job because of this COVID time, they have a tension type headache. And most important thing is counseling. As per the sir story, that counseling is very important for these patients. Obviously, you have to rule out ophthalmic cause. Other than ophthalmology, if you are finding nothing, if everything is normal, then you have to counsel the patient properly. You can't say that go to there. So counseling and reassurance is very important.
Thank you, Ashish. Pushpitadi, your take on this?
I think everything has been said. Basically, it depends on the patient profile that you're dealing with in your clinic. Just Dr. Mukherjee, he deals with mostly rural patients, whereas those who deal with urban patients who have been shopping doctors and they come with sheaf of documents, those are the people that you have to tackle, diplomatically, because you need to explain to them. So I think there's nothing further. These days, everybody's under a lot of tension, so you're going to get a lot of headache. I don't think there's anything else to say.
Okay, thank you so much. Swati?
Thank you. Yeah, so I'd like to congratulate Dr. Jairam for the excellent talk. And for me, what I feel is that when a patient comes to the clinic, I feel for me, the clientele I have, many of the patients are having more of a psychological headache. Once we are done with the refractive correction and checking all the causes, but then, and if we don't find anything, it's not that we tell them you have nothing, you go home. That is not done. We need to give the due importance to the psychological headaches or the mental entity. It's not just the physical entity, cells flares are there or not, or there's a disc edema or not, a refractive error or not. We need to give the due diligence or the due importance to this psychological component of headache. And it's very well dealt with, and we do need to remember this in our flow chart. So with that note, I think we can move forward. And again, another thing is, as for the stress-related factors, it's not just always that job chala gaya ki nahi, kiya ye ho gaya ki nahi, or a family death. A person might have a different wavelength in the threshold. A person might be disturbed with just a very small thing, which may not be significant for another person, and a person may not be disturbed with a very significant mishappening in his life. So I think we should respect everybody for their wavelength and things.
I just wanted to mention one thing. Thank you. Yeah, no, you're absolutely spot on. What I did not mention, one of the more worrying pattern is I worry about people with chronic analgesic overuse, and they don't kind of, go around shop doctors. I think that is the category where we have to push all our energy, because some people take astounding amounts of analgesics, and there we have to, I think, be very, very careful.
Actually, so before your talk, actually, I mentioned that point. So I try to give extra time to these patients to actually counsel myself, though I'm not a counselor. I might be interfering, but definitely as a practitioner or a medical person, I think I do it within my limits. And then if I feel that it is not done, definitely we have to refer after a particular point. So I think with this note, thank you so much. We'll move on with our next talk, which is by Dr. Arjun Dasgupta. Sir, please, the floor is yours.
Thank you. Thank you, OSWB, for letting me share our point of view. Our means the ENT surgeon's point of view in this forum. And it's a galaxy of stars in there, and I feel intimidated, but I will try to do my best. So thank you, Rajesh Da, thank you, Shogata, and here is where we come from. So the topic was given to me, the ENT question of headache, the answers in the sinuses. I put 3 question marks in there. I must mention, this is Dr. Mohan, this is me, Dr. Datta. Actually, Dr. Mohan was supposed to give the talk today, but he had a problem, so I'm giving that talk. The reason why I put the 3 question mark is the headache of sinus origin is hugely debatable in the ENT circle. So I'm going to share some of our internal contradictions with you. And it may be a little bit boring because some of them are really, really academic, but it's important to know because it's a common perception that sinuses cause headache. Now, I can tell you a secret that the sinus patient that we see day in and day out usually do not complain of headache. It is usually the heaviness of the somebody has got the microphone still open. It is usually the heaviness of the sinuses that come. And yes, we get a pain. When we get a pain in the sinuses, then it is actually a warning sign because things are really, really bad. So we get an awful number of headache patients, and we have started to come out with a name called rhinogenic headache. So what is the rhinogenic headache? Well, we are going to do the diagnostic criteria, try to define it, the history, examine the evidence, and discuss some recommendation. And I'm supposed to finish that all in 8 minutes. I will try my best. Okay. So basically, is the headache, the sinus headache. There are major factors for sinusitis and there are minor factors. And as you can see in here, the headache is in the minor factors. So we don't consider headache to be a major diagnostic criteria in sinusitis. These are purulence, facial pain, nasal obstruction, fever, hyposmia. These come much more important, and it is really true. We see it day in and day out. So the rhinogenic headache is a headache or the facial pain secondary to the mucosal contact points in the nasal cavity. So other words are rhinologic headache, rhinopathic, sinogenic, middle turbinate headache. So there's a lot of names, we use them all. So there's one term, if you remember, it is called the mucosal contact point in the nasal cavity. Because what we have seen is when two sides of the mucosa touch each other, there is a rise of pain in there. And we have found ourselves in the International Classification of Headache Disorder. So I'm not going to bore you with this, but yes, mucosal contact point headache is there. It's classified right now. The historical perspective, it was first described by 1880. That's an awful long time ago, just after the Sepoy Mutiny. But Sluders described the vacuum headache, and McAuliffe in 1943, he did some pretty good studies. So just to let you know that what he did in 1943, he was trying to touch different areas of the nose and trying to ask the patient to point it out where he was feeling pain, and his finger was dipped in soft red wax. So they were trying to find out that yes, there are different parts of the nose can give rise to pain. And he also could not elicit the pain in the back of the head. So he said that usually there is superior parts goes to the head, the inferior part of the nose goes to the tooth, jaw, and all these areas. If you don't know this person, this is called Stamberger. Stamberger is more or less the founding father of modern endoscopic minimal access surgery. So we all learned to become rhinologist after this man. He said there is three classification. They're clearly connected to a sinus problem or clearly identifiable non-rhinous origin, migraine, and identifiable causes. So he did a lot of study on it, and he proposed that there is a substance P. I'm sure the neurologists will agree. And they are secreted by the nasal tissue in unmyelinated C fiber that causes like the vasodilatation and other phenomenon, and those are the one which causes the pain. So this is a CT scan. I'm sure ophthalmologists know all this. This is the eyes, and this is the septum. As you can see, the septum has bent and is touching one of the lateral wall. So these give rise to the pain. So this is a theory. And it goes to the V1, which innervates the dura and the intracranial blood vessels. And the substance P is more or less the final common pathway of the migraine. So that's the same way the rhinologic pain, rhinogenic pains occur. And there is plethora of studies. Don't even go into there. If you want these studies, I will send it to you later. In 1980s, 1990s, there are like hundreds and hundreds of papers which kind of corroborated the same thing, that the nose give rise to pain if two mucosal point contact with each other. It's very easy to prove actually in the clinic. What you do is basically if you first identify the area, then you locate this with an endoscope, then you just put a little bit of cotton with some local anesthetic or a small injection over that contact point and see whether that resolves the headache. This is a very good technique trying to find out whether the headache is from rhinogenic origin. And it's important that the patient has been evaluated by physician of other specialties like neuro, ophthalmologist, and internist, and other people. So there are some contact points which are common. There's septal deviation, septum to middle turbinate, septum to inferior turbinate, concha bullosa, superior turbinate pneumatization, any other mucosal visualized mucosal point. So fantastic. We have a theory. We have proven the theory. We have a physiology and the pathology to back it, and we can demonstrate it. So what's the problem? The problem is most of the times this McAuliffe finding has not been reproduced. So even if you stimulate them, that doesn't always mean that there will be a pain. And also in the rhinologic pain, that the mucosal contact point theory, one of the main criticism of that is anywhere else in the body, if two mucosal surfaces comes in contact, they don't give rise to pain. So what's so special about nose? Why in nose two mucosa comes in contact with each other and causes pain? And as Dr. Jairam has very correctly says, that all this, they have said that all these patients should have 6 weeks of amitriptyline before evaluating any of this patient. And I kind of agree with them. The amitriptyline is a fantastic drug. And the relationship is called into question. However, there is some long-term studies. So when you talk of long-term studies, there is 10-year studies. So they have seen the intensity, frequency, and duration, and they have found that 13 out of the 20 patients in 10 years who had some form of surgery, like this deviated nasal septum, which has been corrected, actually has improved. So we have some long-term study which supports of the mucosal contact point theory or rhinogenic headache. And there is also a big study which is a CT criteria, and they have said about 85% of the patient has improved in the long term. So these are good evidence. So in balance, we can say the number of patients treated are low, the multi-center studies are needed. So we need more research. I mean, there is nothing to hide. We need more research in this area. So the rhinogenic headache, even in the ENT community, as I'm speaking now, is very controversial. It remains a diagnosis of exclusion. Before surgery is considered, the patient should be told that this is a controversial and disclose the controversial role of the surgery, that you have to explain even after you've done a pledget, like you put a cotton wool and that has relieved the pain, you still have to explain that even after all this, this is exactly what I say, that if you are willing, I'm willing to go in there and correct this deviation or whatever mucosal contact point. And if you don't improve, then I will unfortunately have to send you back to where you came from. And only if they agree, then only you should go ahead with the surgery. Otherwise, this patient is going to be after you for the rest of your life. Thank you. This is my team. This is Dr. Mohan, Satpathy, myself, and Dr. Datta. We are working for the last 16 years as a team. And these are the references. Thank you.
Thank you, sir. That was a very extensive talk. And I'd like to ask Dr. Subrangshu. Dr. Subrangshu, yes. So a patient comes to your clinic and you've ruled out the causes of the ocular causes of headache, but you find he has a nasal congestion or something. So do you deal with the patient there, or you ask him to go for some steam inhalation or hot fomentation or X-ray of PNS, or do you move for or refer the patient to an ENT person?
Are you asking me? You're asking me?
No. Yes, sir, anyone can take the question.
Oh, sorry.
I think, yeah, Dr. Dasgupta, with reference to actually, I mean, we as ophthalmologists, when we have excluded other causes, whatever has been said by all the speakers absolutely summarized as to how we should approach, overall a patient with headache. From Dr. Gandhi, we could not estimate the role of confrontation, getting the visual fields done. I actually tend to, over prescribe HVF 30-2s. Then from Mrs. Biswas, yeah, definitely so many small nuances she dealt with. we have to talk to our optometrist whenever we have any doubt as to, like this, or even with a 6 vision, why is the patient still complaining? Then, of course, from Dr. Jairam, we learned we have to give chair time to the patient. That is probably what is most important. Like, for example, in tension type headaches, we often find, like Sir said, patient ends up describing the other body aches in such great detail that they give you a very, important clue that you might be, dealing with a tension type headache. And finally, when we end up with probably an ENT cause, we as ophthalmologists probably prescribing an anti-allergic and asking for steam inhalation, and then if it's not getting better, go to the ENT surgeon with an extra PNS. So, sir, Dr. Dasgupta, sir, how would you? I mean, what is the role of steam inhalation actually? And of course, I must say that on a personal note, I was rather sad to hear that headache is actually one of the minor causes. I mean, one of the minor problems associated with sinusitis. So I would actually dump most of my unexplained headaches to, probable sinusitis. Sir, over to you.
Steam is brilliant. Steam does wonders. And if the steam helps to cure the headache, obviously that's pointed out towards the rhinogenic headache. If it doesn't cure, then probably you have to think of other causes. But if the steam kind of reduces the headache of a patient, then most probably it is a rhinogenic headache. But I think I need to mention one thing. We have moved far ahead of the X-ray PNS. X-ray PNS is very controversial in a way. It gives a lot of false negatives and it confuses more than it gives answers. So we tend to, if needed, do a CT scan or don't do anything at all. I mean, we have kind of stopped doing X-ray PNS nowadays, unless it's a child or there is some medical legal issues or other things. So yes, I think you should give a steam inhalation, and then if you are convinced it's a rhinogenic headache, send it to us. We will look after it.
Arjun, while you're at it, there was a question from one of our audience member that she wondered about cold triggered headache. So what is your take on that? Cold triggered
headache was in the part of the lecture given by our esteemed neurologist, Dr. Biswas. I think he will be a better person to answer that. In a myriad of different causes for headache, I have seen the cold triggered headache. It's definitely, we do come across from time to time, but I think this is more of a neurological problem than an ENT issue.
Yes, Dr. Biswas.
Yes. Actually, cold is a trigger for even migraine, but cold trigger headache is one of the primary headaches. Even those who are not suffering from headache can have a cold trigger headache. Exposure to cold, particularly the weather, or maybe by consuming food that is cold, that can induce a headache. And sometimes the neuralgic headache, like the trigeminal neuralgia, can get associated with exposure to cold by cold wind or by chewing something or swallowing ice creams. So cold trigger headache can have many diagnoses. One may be migraine, one may be trigeminal neuralgia, or maybe a variety of primary headache apart from the migraine.
Thank you. Dr. Biswas. Sorry, Swati, go on.
Yeah. So, Dr. Atanusha, there's another question for you from Dr. Prachi Subedar Ghosh, and she's asking that she had a patient of known his case of migraine on beta blockers for 14 years, and who came up with a history of sharp headache, and her MRI and ophthal findings were normal. So, how do you go with the management of that case?
Yes, this is a common problem because the chronic headache, probably a chronic migraine headache, difficult to manage. And of course, we know that migraine, if it lasts for a longer duration, the pattern of headache changes. And this is the sharp headache or the or the pricking headache. Maybe a variety, it can happen to a migrainous patient at some point of time. Or it may be, there may be additional other type of headache. Patient might have two varieties of headache. One may be migraine, another may be a neuralgiform headache. Sharp, shooting, electric shock-like, pricking headache can be because of the neuralgiform headache. But probably this patient, as she's having a long duration of headaches, she's probably having a primary headache, migraine headache, and chronic migraine, which has now changed its character from a typical like that of the pulsatile character of the headache to become a sharp shooting character. Managing these patients is very difficult because the beta blocker, we do not prescribe for a longer duration for more than at least 12 years. But in these patients, as he has been taking for beta blocker for long duration, either you have to change to some other medicines. Nowadays, the host of prophylactic medicines available, even including the monoclonal antibodies now has come up. So management will be depending upon the need for the patient, his or her the body weight and the age and everything. Considering all these things, you have to choose for the prophylactic.
Thank you, sir. Thank you.
Yes, there is another question for Dr. Biswas, which Dr. Biswas can take probably. This is for Dr. Ram, but he had to leave, unfortunately. Dr. Biswas, there is a question where one of our colleagues has suggested that whether gabapentin has any role for treating tension type headache or not.
Maybe that tension type headache, Dr. Ram told you that amitriptyline does wonder in many of the tension type headache. But apart from amitriptyline, there are other many drugs which can be used. Gabapentin is one of them, of course. But actually, for treating a headache with the gabapentin, it requires a dosage that may not be the patients or the usually the sufferers may not willing to take this, because gabapentin needs to be given thrice a day. It needs to be given for a longer duration. So amitriptyline is a better choice than the gabapentin. And gabapentin, of course, has a very good side effect profile. That is true. But once if he is intolerant or there is a contraindication for gabapentin, one may choose for other drugs. One of them may be a gabapentin.
Thank you, sir. We understand that uncorrected refractive errors, overcorrected myopia, computer vision syndrome, systemic hypertension, and there are innumerable causes which we need to look into. And yes, Subhrangshu.
Yeah, if I may just bother Dr. Biswas a bit more. Sir, where do we stand as far as calcium channel blockers for migraine prophylaxis? We generally, as ophthalmologists, end up prescribing only calcium channel blockers. Where do they stand actually from the neurological point of view, sir?
Yes, it has a definite role for this. Particularly this sponsor of this company, of our program, this flunarizine of Cy William. This is widely used all over the world as prophylactic treatment for migraine, but it has some limitations. You cannot use it for a longer duration. You have to use it for 3 months or 6 months or so. Then if the patient does not respond, you need to change it to some other. And maybe by combining this, we sometimes use the flunarizine along with beta blocker or something. It has some side effects also. You have to keep in mind that those who are obese or having tendency to put up weight, they have to, you should not use this. It also produces some depressive symptoms. So, but this is a good drug, and this is convenient because you can use it once daily. And this is is still used, and most of the neurologists, ophthalmologists in this country, they find the fluorinazine to be a good drug for migraine prophylaxis.
There is another question. This question is about computer vision therapy. Now, I would like, first of all, Nina to give her opinion about what type of program she uses, whether she at all uses this computer vision therapy in her clinic. And if so, one of my colleagues has asked, what is the best type of program to use?
There are various programs available, like we have a Binoc vision therapy program available, made in India by...
How expensive?
It's not very expensive. It's like we buy it for about per session is for about 150 per session, and you can give it for 300, 400 per session. You need about 10-20 sessions once a week, twice a week. So 20 sessions are good enough. So the patient 5,000 or 6,000 patient has to pay, not too much.
For the whole 10 sessions?
For the whole. That's a Binoc. International ones are expensive, but they are also good. HTS is one of the international one. HTS is the one which we use as international one.
Devdas, you wanted to say something? No, I think he went away. So I'll ask probably.
I have a question. If
yes, go on.
Is to Dr. Guho or Dr. Biswas. As an ophthalmologist, as Dr. Shubhranshu has said, that we quite often prescribe drugs like Civilium. But at what point we should rethink that our diagnosis and refer the patient to neurologist, or shall we change over to another drug like topiramate?
For primary headache, I don't think you should always refer to the neurologist. But when you are finding that it may be something else, looking like a secondary cause for the headache, or if you are having any doubt that this person is not responding to your optimal prophylactic treatment, you need to try some other thing like applying the botulinum toxin in the head, or you have to just give some modern treatment modalities. You may refer him to a neurologist, but I don't think for treating a common migraine or for tension type headache, you don't need a specialist like a neurologist to be referred. And for investigations, I personally, we do not prescribe imaging for each and every patient. When there is a classic features of migraine or tension type headache, you may not advise imaging, but for this medical legal purpose, sometimes you are forced to do for some brain imaging. But some prefer MRI over others imaging, because MRI gives you a whole lot of things. And but there is no end. If you have to do the MRI with contrast imaging, you have to do for even the vascular imaging. So imaging is not always needed, in particularly those where you are suspecting a primary headache or a chronic headache sufferer. And for management of the patients, I think the ophthalmologists are well capable of managing the patients of headache in their clinic.
Okay, there's another question for our panelist neuro-ophthalmologists. I'll ask Sujata and Paramita. There's a question where there is a observation that migraine is more common in females and it lessens with age. Do you agree? I mean, what is your experience in each of your practice?
I would like Dr. Biswas to answer this question, because he would be seeing much more migraine patients than we do. And I would also like to ask Dr. Biswas how difficult it is to differentiate between chronic migraine and chronic tension headache, because they kind of have many overlapping symptoms, but their management is quite different. For both, could you just elaborate a little bit?
Yes, regarding your the gender, difference. Of course, the migraine is more common in excuse me, more common in women, and usually there is a tendency to improve the headache as age progresses. But actually, there is no specific age at what point of time you can say that this after you have crossed the age of 50 years, you don't have to worry about your headache will go away. It is seen that patients may continue to suffer even after the age of 50 or 60s. So although women suffer more, but the specific, yes, it reduces the intensity and sometimes it disappears, but there is no clear age limit after which point you can say that you are free of headache. And regarding your second question, differentiating a chronic sufferer from whether he is having migrainous headache or a tension type headache. Yes, it is purely clinical, and if the symptoms, sometimes it overlaps. One person might suffer from both types of headache. Sometimes on one day he might be having headache typical of pulsatile nature, hemicranial, and maybe associated photophobia, phonophobia, nausea, vomiting, suggesting a migrainous headache. But at sometimes it is just a pacing headache, a compressing nature, and it is not associated with a severe photophobia, phonophobia. So it gives a difference, helps you to differentiate between two types of headache in most of the time, but maybe in a chronic sufferer, it may not be possible. Of course, the management, the acute prophylactic treatment of with triptans will not help in patients with chronic tension type headache. But many of the prophylactic treatment for chronic tension time headache, they also are helpful in patients with migraine. So when it is
Great, thank you.
you have to apply judiciously which medicine you have to choose. But there is both amitriptyline and other antidepressants are best medicine for the migraine as well as the chronic tension type.
I'd like, sorry, thank you so much, Dr. Biswas. I'd like to ask a quick question to Paramita. Paramita, we talked about the computer vision therapy. So I know that you have a good synaptophy for working synaptophy in your clinic. Do you use it quite frequently?
Actually, when we started our practice 30 years ago, I used it much, much more than I do now. And the role of exercises has really, for some things like convergence, insufficiency and everything, but then not the synaptophore so much. I think the importance of the synaptophore has declined over the years. It does have its uses, but not as often or as frequently as we used to use 30 years ago. I think probably Sujata will agree, I don't know.
Okay. There's one question again for Arjun. Arjun, are you here? Where is he?
I'm here.
Unmute. Okay. The question for you is tenderness of the superior orbital margin. So is that something we would take as a sign of frontal sinusitis?
Not really. These non-specific tendernesses are usually kind of mislead you, because as I said, the most of our sinus patients do not have pain. But like in medicine, everything can happen. I mean, yes, rarely sinuses do complain of pain, but usually when they are suffering from quite severe diseases, when they have gone to like mucosales, or it's severely inflamed, or there are like fungal infections inside the sinuses, then obviously there will be tenderness. But sinusitis are usually the causes of facial heaviness, fullness, occasionally facial pain, but typical tenderness on eliciting in different areas, including the superior orbital rim, is a non-specific sign.
If I can add this for the answer to this question, sometimes there could be an entity called trochleitis, where if you press over the superior nasal aspect of the orbit, a little, inside the orbital rim, if there is an inflammation on the trochlea, you can definitely find a tenderness over there. And these patients also tend to present with these non-specific retroorbital pain, headaches of that side. And it is a useful entity to remember and palpate the trochlear point.
Yes, ma'am. Even I've seen that this coincides with the base of the frontal sinus, and many of my patients I have served with, like, due respect, I've found them like to be positive for frontal sinus, base of the frontal sinus tenderness. And I advise them steam inhalation, hot fomentation, and of course, if they're not responding, then we do need to collaborate with our neighboring ENT people. Yeah.
I have a question in regarding this. If there is a trochleitis, don't you expect some ocular movement restriction?
Yes, sometimes it can present as an acquired Browns, but very often it is not so severe that it will cause an elevation in restriction of elevation in adduction. So many a times they will present very innocuously with just a retroorbital pain, which is not going with migraine medication, analgesics, nothing works. And then if you do a MRI of the orbit and find some point in the trochlea which is a little enhancing, it pinpoints a diagnosis, though MRI may not always be positive for these patients. And it is very useful to inject a combination of a steroid and a lignocaine in that area. It's pretty simple to do, and it is very effective. So this is, again, an exclusion, a diagnosis of exclusion.
Yeah, I think for MRI, we have to really specify to the radiologist that they have to look at that particular area, because sometimes they're not exactly sure what they're looking for. So you have to really tell them that you need to focus on that trochlear area.
Yes.
And we have nowadays in a good machines, 3 Tesla specifications, so they are pretty good actually. I have a question for Rashmin. Rashmin, thank you so much for hanging around. There is a question for you, which is there any role for vitamin D and magnesium in treatment of migraine? What is your take on that? I know Dr. Biswas is there, but still, you are from our side, so I would like to ask you. Are you there, Rashmin?
Yeah, hi, I'm here. So no, I have absolutely no experience with either of the magnesium or vitamin D. And to be very frank, nowadays most of these patients, I take the help of our neurologist colleague quite early in the management of the patients. Once we know that there is no neuro-ophthalmic feature, I involve them right in the beginning, and I have no personal experience with either magnesium or vitamin D.
Dr. Vishwas?
I also don't have any personal experience of using these drugs, and there is no recommendation from any society for using these for prophylactic treatment. But yes, very many combinations are available with amitriptyline and even nowadays the methylcobalamin, and like vitamin E and so magnesium. Maybe they may be effective, but I don't have any personal experience on this.
Thank you. Swati, you want to ask anything? Shugato?
No, thanks.
So I think we're coming to the end of the road here. It was a great journey for both of us, although there was a little bit of technical hitches in the start, but we did well. Let's pat ourselves on our back. It's a great talk, great panelists, especially great chairpersons. Really proud of you, both of you, Devdasta and Pushpitadi. Shugato, you can take over from here.
Yeah, Rajesh, I would like to repeat the same. So thank you, Chairperson Pushpitadi and Devdasta. Thanks to all the speakers, Dr. Biswas, thanks for taking our invitation. Then Rashmin, I have forced him to take this talk. He's probably leaving for Africa next week. So thank you, Rashmin. Thank you, Arjun. Arjun is always helping. Thank you so much. He agreed in the last moment because our initial speaker, Dr. Mohan, couldn't join. And thank you, Dr. Nina Viswas and Dr. Ram. Dr. Ram has to leave. And thank you, the panelist, for your input. You have devoted your time in spite of your busy schedule. Thank you very much. And both the moderators, thank you so much. And I would like to thank Dr. Dr. Oyan Mohanto and Shogato Giri for the technical support, and Johnson & Johnson Janssen Group for sponsoring this meeting. Rajesh, you want to say something?
I just wanted to add something. I'm really sorry, after a vote of thanks, but I would like to thank Ashish Bitpuria. Ashish is from Disha, North Bengali, and he's never participated in the OSW meet in the past. So Ashish, welcome to the fold. We are not really that bad. So I'd like you to be part of our gang and part of our team for all our programs in the future. Okay? Definitely. We want you and all your friends.
Yes. See, OSWB actually is trying to involve people from all over Bengal. So it's good. Ashish from North Bengal, then Devdasda from Malda, and Pushpita from UK at the moment is involved in the meeting. Thank you so much.
One question to Pushpita. How is the atmosphere in UK? UEFA semi-final. Are they mad now?
This is besides.
That's usual. Everybody's mad in my house as well, apart from me.
Yes,
apart from you.
To stay awake as well.
You are looking for East Bengal or Mohun Bagan.
Well, personally, I prefer cricket. I'm looking at the Wimbledon.
Still, you are in UK. You must support England.
I don't like the appearance of the footballers. Sorry about that.
Yeah.
I think cricket is a gentleman's game.
And we can still carry on with the meeting. If Shogati is here, you can stop the live transmission.
Yes, sir. Yes, I am stopping it.